Good morning, everybody. Thanks for being here. In fact, I thought I was going to be alone. It's the last day, and only educational session. So thank you for coming. I'm glad to see young people and other colleagues that for sure they have walked the same path as I have walked in this presentation. So the title of the presentation is How I Treat Low and Intermediate Risk Neuroblastoma of Childhood. And I have no conflict of interest of importance. And in fact, it has not been an easy session for me to prepare. First of all, I had to go back to the definition and try to figure out the audience to whom it was devoted. And that's the definition as it stands in the meeting program. So I try to adapt to that. I will go through a brief historical background and then explain how and why we treat, or at least I treat, because this is in singular, it's myself, I treat these cases as some thoughts that are also personal to take home. Okay, so let's go. I'm not going to talk at all about biology after the outstanding sessions that we had yesterday, not only on high risk and relapsed neuroblastoma, but also on intermediate risk. So that part, I think that most of you were there, and I will not touch it, at least in depth. So I try to start with this painting. This is a painting by Joaquín Sorolla. In fact, they are not doctors. They are women taking care of a child, so and a healthy child. So, but I love this picture. He is from Valencia, as I am, and for me, the painting reflects what I try to do in my professional life, is to take care of any child with cancer, not only neuroblastoma. So I think it's a good starting. I started my career in 1995. I was stimulated by my boss to go abroad when I finished my residency, and that was my first contact with the neuroblastoma field. It was at the same time as the LNSG1 started, the first European trial on localized neuroblastoma, And right now, currently, I'm leading LINES, and this is going to be the end of my professional career for sure, because I have a long time, and young people, as you are here, will have to lead the field. So I'll try to go through this path with you. So the first, and that will let you understand why we treat low and intermediate risk neuroblastoma in Sayopen as we do it right now. The first trial was the LNSG1. I think that these four people, Bruno De Bernardi, Daniel Beck, Jan Michon, and Andy Pearson, that some of my more senior colleagues here know, were the ones that had the vision that we have to cooperate in pediatric oncology, and they set the field to do it with this very simple study or trial as we see it with the eyes of this time. We just demonstrated that surgery is enough to treat children with neuroblastoma stage 1 or 2 of the INSSG. And that set up also the basis for something that is very important today, is the staging system that we are using based on imaging risk factors. So I think that they deserve that you know them quite well, because it's the beginning of our study. In 1999, also the European group launched the Infant Neuroblastoma European Study. It took us several years to set it up. I had the privilege to be leading one of the smaller groups of that trial, being very young. So thankful the ones that gave me the responsibility. But basically, for the low and intermediate risk, what is of importance for us is these three groups, because this is the backbone of the current LINES trial. We were able to demonstrate that infants with stage 3 and with 4S, at that time that was the staging system, had an excellent survival, most of them. We could avoid anthracyclines in this group of patients of localized stage 3 neuroblastoma that had an excellent survival. Infants with stage 4S disease, again, had an excellent survival, and some of them had even no chemotherapy. I have to remind you that in the other trial, we, even in NLSG1, we even did not use NMIC amplification for stratification because it was defined around those years. So for these patients, we did separate one group of NMIC amplified infants, but for the rest of them that were not amplified, we were able to, even for stage 4S neuroblastoma, who did not have life-threatening symptoms, had an excellent survival. And there is a small group of patients, of infants, that can be cured with conventional chemotherapy and surgery, even being metastatic when the metastases are in several places like bone, CNS, or lung and pleura. So this was the second study at that time in the European group. And the third one, that is in the backbone of LINES, is what we call in Spanish EUNS, the unresectable study led by Jan Koller and Alberto Garaventa. Sorry, I forgot to write the name. But what is of importance for the LINES is that there was, we tried to avoid radiotherapy in these children over 1 year of age, older children with stage 3 neuroblastoma. At that time, we treat them with carbo-BP and CADO and surgery, and we tried to avoid radiotherapy in these kids. There was a group, important group of patients older than 24 months of age and with unfavorable histology that did not do well. So with all this in mind, we tried to set up the LINES trial. We started around 2004, analyzing all these studies. At that time, there were already the International Neuroblastoma Risk Group System, several advances in molecular biology and in the classification of age. So all these things were put into the bag, and finally, after a long and a hard delivery, in 2012, the LINES was launched. This is a crowded slide, but first of all, I want to thank my co-PIs, and above all, Vanessa Segura, who is here. Well, Alisa Alspa, who was a colleague from New Zealand that helped us at the beginning in the designing and writing of the trial, and that was essential. She was in Vienna at that time. And Vanessa Segura, that is the current and the only one project manager that the LINES has had. The LINES has been supported economically by the ENCA, that I forgot to put here the logo, the ENCA European project that we had at the beginning for 3 or 4 years, and after that for the Instituto Sanitario La Fe along these years. We opened in 2012 and closed in December 2022 with 918 patients, 433 enrolled in the different groups. Remember that we have 11 groups. It's an umbrella type of trial. I think it's the first umbrella type of trial that we did in SciOpen. And we had one phase 3 randomized prospective trial for one group of patients. The others were multicentric, non-blinded, one-arm trials, and one study for neonatal adrenal masses. We have 17 countries enrolling patients with more than 127 sites. And it has been supported by IAT in the database. It was also the first trial in SciOpen that had quality control on real time for biology and for pathology. For biology, for the low risk, for pathology, for the intermediate risks, because those are the crucial points to stratify the patients. The group of biologists led by Gudrun set up SOPs and published them, and set up that every single case had to be reviewed by the group of biologists before being included in the trial. They have to log the CRF to let the patient be enrolled. And the same for the pathologists that set up the quality control in another way. They are 3 pathologists led by Klaus Beiske, reviewing all the intermediate risk cases, and they divided the cases by countries, the 3 of them, and they review them. So this was embedded in the database in a way that that's what you see when you enroll the patient in the trial. You have to go through all the inclusion criteria, the review is done, and then the patient is enrolled. And you have 6 weeks, this also was the first time that we did it in SciOpen, to enroll the patient. After 6 weeks, the patient cannot be enrolled in one of the trials and goes to a registry because we didn't want to lose the data. So that's the way that we set up that. And now it's closed for recruitment, yes, but we still have to do a lot of work in order to analyze the data and have the data mature. It's not mature enough to be published, and but we have to keep working. And our main work now, carried out by Vanessa, is to chase the data, to clean the database, in order to analyze all the data that we have. We think that by summer we will be able to analyze most of the data, we hope, for at least the most important groups for us. In the transition time, we managed to be included in the European Reference Network guidelines that we are doing. We did it for the low risk because this is a more settled field for us, and you have available there. We published one of the subgroups, the neonatal adrenal masses. We know that observation is a safe approach for babies younger than 3 months with adrenal masses. And for the intermediate risk, I just put a question mark because it's still something that we have to work. So far, our results are not bad, and at least we never went through the stopping rules, so it's a safe approach. Of course, we use the diagnostic criteria that are published and are the gold standard for neuroblastoma. I just put them here for you to recall. And that's the schemes that we are going to explain a little bit, just a little bit. Basically, we have 2 main groups, the low and the intermediate risk. They are stratified according to age, stage, and clinical symptoms. For the low risk, the genomic status is mandatory, and for the intermediate risk, the pathology. That's for the stratification. Later in the trial, we realized that for the intermediate risk, biology was also an issue, and it's also mandatory, although not for the stratification, to perform all the more complete biological studies. At the beginning, it was a research question. In the middle of the trial or in the last years, it's not a research question, it's just a very important question. So for the low risk, we have 2 subgroups, the L2 and the MS, and both of them are classified according to, of course, non-amplified, according to the presence or absence of life-threatening symptoms, and in this case, numerical or segmental abnormalities. For those patients with segmental abnormalities, they have chemotherapy based on carbo-BP and CADO. Those are well-tolerated schemes for younger children. You can do it even in the day hospital with no problem and avoid inpatient care. Psyopen centers are very used to these schemes because are the ones coming from INES, so we have a lot of background there. For the cases that have life-threatening symptoms, you have to start chemotherapy in order to salvage the symptoms. Once the symptoms disappear, you can stop the chemotherapy. There is not a number of fixed courses of chemotherapy to perform. And for the ones that there are no symptoms and numerical abnormalities, MS are observed and surgery is not mandatory. But for the localized, we completely failed. We planned a randomized trial in order to demonstrate that observation was a safe approach, was okay and better than chemotherapy. We could avoid chemotherapy, but we closed the randomization with only 33 patients. Why? We still don't understand why. Probably because there are strong feelings about treating or not treating according to different centers or countries. But this was one failure. So this is our low-risk patients, as you see. We consider very low risk those who are neonatal adrenal masses MIBBG positive. This small study of neonatal adrenal masses, it was also very interesting. And this is how we ended the recruitment in December. This was the presentation that we did, the update in our AGM back in September or October, I don't remember. This is the accrual according to the patients, the events that we observe, and the medium follow-up. Some of the groups we were not able to reach accrual, like, for instance, this one with segmental chromosomal abnormalities. But anyway, at the end, we close the recruitment because we will never reach the number that we thought. So this is the current situation. And I want to point out, to remember just the life-threatening symptoms. We have a very nice classification that comes from the infant neuroblastoma, the INES, and that when you see it in the paper, it's very clear. When you see a child with severe symptoms, it's clear. But there are some kind of gray aspects always that can cause some confusion to the clinicians. For those patients with life-threatening symptoms, you have to consider immediate treatment, but it's not easy always. And there are 2 points that I think that are very important: the spinal cord compression and the definition of abnormal function over 2 levels and so on, that sometimes may be great. Also, another definition that gives you room to do whatever you consider as an individual clinician in front of a family or a patient. It's a very larger tumor volume causing concern and so on, about of a rupture and so on. So this is not easy. For the spinal cord compression, I want to that you pay attention to the fact that we can have several clinical aspects in different children with different ages, but above all, it's very important to pay attention when they are really infants and toddlers, because some of the symptoms you need to be aware that they are there in order to prompt some therapeutic intervention. Thanks to Stefania and Shifra that yesterday explained so well the spinal cord compression, involvement study in Psyopen, we know that motor deficits and pain are the most common symptoms that they can improve. We know that you can start with chemo or with a neurosurgical approach, mostly chemo in these times, but you could not forget the neurosurgical approach sometimes, and that means that you have to have a very good collaboration with both teams, not only the doctors, but also the daily watching of the child in a hospital. So it has to be a very excellent care. And of course, you have to be very cautious when they are infants, because you can have a very sad end if you are not cautious. Okay, we come back to the low risk, just this to review the same that I have explained before, and some of the cases that in the paper may look very easy, but in real life, well, it's like, oh my God, what are we going to do with this huge tumor located in some complicated space? Well, we can treat them with this approach safely in centers that are prepared for that, always. Just remember that. I think these are very basic messages, but as this is educational, I think it's good for all of us to remind this. We have several other cases so heterogeneous as neuroblastoma can be in this field. Remember, these are not high-risk patients with maybe little fever, maybe pain, metastasis all over the place, and so on. So this is the aspect of the low risk. For the MS, it's also very interesting. We may be safe. We are safe with the observation approach, but it's not easy to proceed. Sometimes when you find segmental chromosomal abnormalities in an MS patient, you say, oh God, we can treat them with chemo and BP. So it's important also to be brave. It's clear that when you find a baby with this belly and this huge metastasis in the liver and the tumor, you are going to treat as much as you can in a very elegant and excellent way. And sometimes most of the times it's okay, but sometimes it's not so okay. So you have to be very careful. But you still have to know, if you are observing, when you have to treat them. What's the point that makes you change your attitude? And that's something that we define in the LINES. Of course, the development of life-threatening symptoms, as is in the list, it's an important one. The local increase of the tumor volume without life-threatening symptoms is not an indication for starting chemotherapy. And sometimes it's not easy to be in this position. And, of course, the development of metastatic disease. Once you have the suspicion that this is happening, you have to do the staging again. Why I said that sometimes it's not easy? Lately, we had a preterm baby in my center, twin. There were two babies, but one is the one with the MS. Preterm, it was roughly, I don't remember if 2 kilos when he was born. And at birth, we already saw a neuroblastoma, an MS neuroblastoma with a right adrenal and liver metastasis all over the place. He was biopsied with TrueCut in the liver, and the genomic profile I put here, numerical chromosomal abnormalities, but in fact is one of the cases that has no result. So we treat it as the INES, what it says in the protocol. And he looked well all the time with a big liver and mass. So we, at the beginning, started to watch carefully. He was gaining weight. It's well. Lactancia materna, you know. Sorry. Weekly follow-up at the beginning because parents were scared. You are confronted to a cancer with liver metastasis. So it was like 1 hour, 1 hour and a half every time they came to the clinic. And around February, the tumor increased a little bit and the liver function enzymes rise. A little bit over the double of the normal value. A little bit. It was not 3 or 4 times, but a little bit. But according to the list, this is a life-threatening symptoms. So do we treat? Parents were scared. The kid at that time was around, I don't remember, 3 kilos, roughly over 3 kilos. So we decided just, he looks well. Just came back next week, and we will see what we do. So he came back the next week, and he was fine. And the liver function just recovered a little bit, not the tumor. The tumor was the same size. So we keep watching, trying to lapse the time of visits. And now in May, we already see some regression clearly. So at least so far, we have avoided chemotherapy, and he is around, I don't recall by heart, probably 5 kilos. And they come both twins to the clinic, and they look the same. So it's something a message to take home. Changing now to suprarenal adrenal masses that has been published, I just want to recall you the importance of doing the staging, complete staging with MIBG. There was also some strong feelings about doing MIBG in these small babies, and in fact, it was informative. Some of the centers did not follow the whole protocol, and we don't know who or how, which were the masses that regressed, but for more than 50% or 70% of the cases that were MIBG positive, most of them could be observed. And in fact, there was a small 1/3 of them that had to be operated at the end, but some of them were neuroblastoma, some of them not. So this is a very safe approach for us. Going to the intermediate risk, this is a different heterogeneous group of patients. I'm not going to talk about the L1 amplified patients that we were only able to enroll 2 cases. One was alive, the other one was dead. And this is a very special group that we don't know how to treat. I remember when I started that for the LNSG1, we had one patient in Valencia that it was stage 2A, I think, or 1. It was a long time ago, back in the 1996, that relapsed with bone and bone marrow metastasis 1 year after being operated. And at that time, we figured out that it was amplified. Remember that at the beginning, NMIC amplification back in the 90s, it was not included. It was a research investigation. It was not included in the standard of care. So this is a very, very, I have never seen another case like this in my center or in, this is a very rare group of patients. For the M patients, group 10, I'm not going to talk because it's exactly the same approach as the 99.3, and probably we are going to have the same results with more patients. In the 99.3, there were, I think, 45 patients, and here we have more or less the same number of patients in those 10 years. What the group that it's the one that concerns us the most is group 7 and 8. Group 7 are differentiated, and these, I think it's important, the surgical approach. And group 8 is, very special for us, the poorly or undifferentiated over 18 years of age, that we included in this approach radiotherapy and cisretinoic. Why cisretinoic? Because at that time we wanted to somehow, in the EUNS study, there were also metastatic relapses, and there was no radiotherapy. So for this, we had the same chemotherapy, the best of the surgery. We included radiotherapy and maintenance treatment, like a prevention of minimal residual disease. At that time, it was with cisretinoic acid. We didn't have the dinutuximab beta for these patients. So for this group of patients, as we included radiotherapy, it was also the first time that we tried to do a radiotherapy review on real time. It was also the beginning of Quartet, so the beginnings of the radiotherapy review here at Linis was not easy for Vanessa nor for Tom, but we have been doing it since then. These are the cases, like a group 7, where here I think that the surgeons have a lot to say, and to achieve. We are working with them to analyze all the data that it's in the database, and we are trying to clean. And this is how we are now for the group 7. That's the target. We target 25, but we only have 16 patients. It's not easy. And we close the recruitment when we reach for group 8, 88, because our target was 85. Okay, so this is what we see for group 8 in the clinic, as you can see here. And that's the numbers. So what, as I told you, I was not going to speak about biology. Now we know that biology is very important, that there are a very small group of patients that need to be treated with a more intensive or different approach. We don't know yet, because we will have to analyze all the data. But that's how we are working now. So this is almost the end of my trial, and I just want to recall you the importance of carrying out multi-collaborative trials in Europe. We did not succeed in launching a randomized trial for Group 8 at the designing of the trial, and I think this is an important failure for the whole community here, because indeed now it's what we need to know. But again, we did not succeed in completing randomized trial to demonstrate a spontaneous regression in L2 tumors in children below 18 months of age. Because in the end, we all know that randomized trials are the ones that answer our scientific questions, but in our daily lives, we have strong feelings about how to treat or not to treat a patient, and probably that still impacts in this type of approaches. But those were the drawbacks. But what are our successes? First of all, I think that we are going to achieve our primary aims and secondary aims as it's in the protocol. That's we have been going through the different DMCs and analyzing preliminary the data, and it looks like that. We succeeded in performing an umbrella trial in neuroblastoma with 11 arms, 17 countries, 126 sites in a 10-year period where there have been so many changes in molecular biology, in clinical trials, and so on. So indeed, it was a great effort, and I want to thank publicly to all the patients and families, for sure, all the colleagues, and in the different sites have been participating in the trial the best that they have they can. And of course, my co-PIs and Vanessa. My first message, and the only one, is that we have to be excellent when we are doing the staging and the treatment assignment for a patient, and that we need to talk to parents quite a lot in this field. For the high-risk patients, for one reason, because it's a very severe disease with a dismal prognosis still nowadays, but for the low and intermediate risk patients also, because they are confronted to a very bad disease, and it's hard to understand that sometimes we don't do anything, and that's for the sake of the child. And for sure, never, never, never forget your mentors. Sorry. Es que I cannot. Ana, I will not be able to do this in Spain. I just want to say a tribute to Victoria, that passed away just when we came back from Vienna. So she was a great mentor and a great person. So come back to life, because this is what she wanted. Questions? No? Oh, young one, yes.
Michal Kir from Czech Republic. I just wanted to ask about the relapsed patients, intermediate relapsed patients. How do you treat them after they receive the whole bunch of intermediate risk chemotherapy?
We upstage them and we treat them as high risk patient. Was that the question, or it was more how do we?
Yeah. So they receive the whole.
Yeah, they receive basically carbo BP and CADO and surgery and radiotherapy. So we try to adapt them to the high risk approach. Most of them, at least in our setting, have gone through either rapid COJEC, topotecan, cyclophosphamide. They have been consolidated also with bone marrow transplantation.
So they receive the whole high-risk treatment?
You have to remember that rapid COJEC has no anthracycline, so. No more questions? So let's go to the meeting. Okay.